there will be many consequences. And one of them, of course, that girls and women will be hit quite hard also, in particular of this pandemic. It has been suggested that, for example, 2.7 million unsafe abortions and pregnancy-related deaths will occur. So these are serious consequences, really. And of course, this pandemic is also some kind of existential crisis, not just for the virus itself, but also how do we live our lives and what kind of sustainable world will we have post-COVID-19. And hopefully you can see this also as some kind of wake-up call that we need to consider what we will put in to the future we have in front of us. Because there is so many things to discuss, and this seminar then will be more of the European, Scandinavian and European context of what we are doing. So very welcome to all of you out there and to also the panel. And for the panelists we have Iris Hunger, who works at the Center of International Health Protection of the Robert Koch Institute in Berlin in Germany. Very welcome. We have also from Norway, Frode Forland, who is a specialist in public health, a medical doctor, and had played, of course, and plays an important role in the Norwegian pandemic discussions. And you're working at the Norwegian Institute of Public Health. And then from Finland, we have two people, Sally Atkins, who is an associate professor in global health and development at Tampere University, and also Liina-Kaisa Tynkkynen, who's an assistant professor in health and social policy, also at the Tampere University. And then from Sweden, Professor Anna-Mia Ekström, infectious specialist and also global health professor. So my name is Peter Friberg, and I'm a professor in medicine at the Gothenburg University and the director of SITE, which is a Swedish Institute for Global Health Transformation at the Royal Swedish Academy of Sciences. And I have the privilege to be moderating this session. So without further delay, I would like to go into the presentations, and there will be 10-minute presentations from each one of you, and Finland had to do 10 minutes for both of you. And please be careful about timing, and also with the slides you have, not to try to impact too much of the discussions time that we will have in the end, a bit longer one. And we might be one reflection or question just after your talks, but then we will continue through all the presentations. So please, Iris, you are the first one out, so please go ahead.
Yes, hello. Can you hear me? Can you hear me fine? Is that okay?
Yes.
Very good. Thank you. Can I see the next slide, please? I think that's the starting slide for myself. Yes. Welcome to everyone. I must admit it's very nice to talk to all of you and to hopefully talk with you later on. It's a bit strange also because I can't even see how many there are, and it's just still very strange to talk to a screen and only see my co-speakers. But I will try and do my best. I have 10 minutes. I would like to describe the response in Germany with a few observations on gender and generally, and at the RKI crisis structures in particular. If I can have the first slide. It's a very complex one, but I will walk you through. I think if we are looking back to the early days of the pandemic, we have to say that Germany has been quite lucky. We recognized our first case very early on. That was on the 27th of January. We recognized it early on because our first case was infected by a Chinese co-worker who tested positive after she had returned back to China. So we were kind of alerted to this possible infection and found the first cases and the first cluster very early on. So we were on the alert very early. Then also our wave, which started in the end of February, it started with quite young or middle-aged but very fit people returning from ski holidays in Italy. So it was not the most vulnerable ones, older age groups, but the rather not vulnerable people. And also, I think, and you see that in the bottom for the January dates, the 14th of January, 28th of January, as a lesson learned from Ebola and Zika, our crisis management structures were actually started very early on. Just check the time. So the Robert Koch Institute, which is the National Public Health Institute, activated its like pre-emergency operation center. It's like a pre-structure and preparation of a possible crisis already in the middle of January, when basically one day after the first case outside of China was recognized. And we went into full crisis mode by the end of January, one day after we recognized our first case. So those three things I do think provided us with a grace period to prepare ourselves. So already early in February, on the 1st of February, we the reporting requirement for COVID-19. Lab capacity was increased, and hospital capacity, including the intensive care units, especially ventilation capacity, recruiting of more nurses, more doctors with ventilation experience could go on. And that actually helped us, I think, to limit the effects of the crisis in Germany. We also managed in a very short period of time to create new surveillance tools. Like we have now a surveillance tool for ICU capacity, Germany-wide, and also for lab capacity. I think it's probably important to remember or to remind everyone, most of you will know, that Germany's health system is organized in a federal way. So the responsibility for managing health issues is with the federal states, not the federal government. So it's with the states, not the head of state, so to speak. That's it. Okay, so 2 weeks after our start of the wave in the end of February, under the impression of the experiences in Italy, the Chancellery urged the federal states to stop mass gatherings and close schools and kindergartens. That was in mid-March, and actually all the federal states agreed and did that. Later, what we now call the lockdown followed, but I think it's important to remind everyone that this was not a complete lockdown. We never stopped public transport. Public transport continued to operate, although it was very, very empty. I mean, there were very few passengers using public transport, but it was running all the time, both local and nationwide. People were all the time allowed to leave their home, not just to go to the doctor or to buy food, but also to do sports outside and walk and for recreational purposes. So they did not have to have a piece of paper saying that they were allowed out like in other European states. So it was not a complete lockdown, so to speak, but more comprehensive contact prohibition. Okay, then that went on for a month. And then on the 20th of March, we actually de-escalated the first measures. And from then on, we have been, with some ups and downs, we have been moving down on the epidemic curve, and we are currently between 700 and 300 new cases daily. Can I have the next slide, please? What is interesting is that if you look at those two maps, the left one shows the, as of yesterday, shows the number of cases overall, the incidence overall. And on the right side, you see the COVID activity of the last 7 days. So the darker, the more cases over the last 7 days. And what you can see is both cumulative, but also last 7 days, is that the pandemic or the epidemic is very unequal. So the south and the west of Germany have been much harder hit than the north, and especially the northeast. And what happened actually is, because of this this diverse development of the epidemic, is that while the escalation of measures was a very unified approach all over Germany, the de-escalation now works in a very diverse way. From latest, where by the end of by the beginning of May, the federal states were not able to agree any longer on a kind of unified response. They said that they would de-escalate state by state, and the explanation for that is exactly the diverse number of cases and the very diverse development of the epidemic that you can hopefully see in these two pictures here. So at the moment, we actually have, as you can see, communities where there are almost no cases. And of course, in those areas, which is like the north and the east, as I said, people want to move forward with de-escalation much more rapidly than in the harder hit areas in the south, where they are a bit more cautious. So overall, we have 100, as of yesterday, 178,570 confirmed cases with 8,257 deaths. We have roughly a population of 80 million. The death rate is 4.6%, and I think this is, especially the number of deaths, is comparatively low. So this is like the current status. What I also wanted to mention is that when we escalated measures, there was also an immense amount of money spent on supporting small and mid-sized companies and the self-employed. There was a lot of money provided for paid childcare leave, so people are allowed to stay at home for up to 6 weeks with full pay. And there's also boni for nursing staff. So for the people hardest hit or at highest risk of infection, they also got some extra money. Now, looking at the situation with a gender lens, there has been a remarkable presence of males in the public sphere on COVID in Germany. People in the beginning asked, are there no female virologists? Because most of the virologists that were interviewed on TV, that sat in talk shows, etc., were male. Names like Drosten, Kekulé, Streeck, everyone knows those virologists now. The health minister, of course, Jens Spahn, and the head of my institute, Professor Wieler, they were also very, very prominent in the news, both male. And then the heads of clinics that were interviewed, also most of them were male. So female commentators have complained about an awful retraditionalization. They said we are back in a male world. They spoke of a crisis of gender equality. And as far as I know, there are no comprehensive studies yet, but the burden of homeschooling that went with the closure of schools and kindergartens was predominantly on women, and the critical jobs, the low-paid critical jobs that kept the society running, such as nursing, such as supermarket staff, they are, of course, predominantly occupied by women. The epidemiological data in Germany are separated according to gender. So we have case numbers for men and for women. We have number of deaths for men and for women. But if it comes to a more detailed information, more detailed studies such as clinical symptoms, then these data are not routinely separated by gender. It is possible, but it's for instance not included in the daily situation report that the Robert Koch Institute is publishing.
So please, Iris, would you like to try to round up now?
Yes, I know. Just one more minute. On the RKI itself, we have two crisis management structures, the crisis management team, which kind of is the strategic decision-making body, and then we have the emergency operations center. And I think we paint a rather good picture here. In the crisis management team, we have 10 male and 7 female members. In the emergency operations center, it's predominantly female, but that actually fits with the overall structure of staff at the Robert Koch Institute. Okay, I can stop here. Thank you very much, Peter.
Thank you very much, Iris. You have any comments about the elderly population in Germany? Any special care you took about those?
Well, as I said, our epidemic started not with the elderly, but it moved more and more to the elderly population. And with that, the death rate also kind of continued increasingly upwards. And we are at a death rate of 4.6% now. We started with below 1. So that was concerning, and most of the outbreaks now, of the smaller outbreaks, are in care homes. And in other populations of disadvantaged people living in very crowded conditions, such as asylum seekers or our latest in the meat factory workers, migrants, mostly from Eastern Europe. Yes, but yes, there is a special focus on the elderly population, and this is also what we always teach people to take special care when they go into those facilities. Yeah,
very good. Thank you. We'll come back to you in the discussion later on. And then I would like to invite Frode Forland from Norway to give you a presentation. So please, Frode.
Yeah, thank you very much, and good afternoon or good morning, wherever you are. Please, next slide. Yeah, come on. We go on with the next slide. So this, I'm working as a specialist director of infectious diseases at the Norwegian Institute of Public Health. And our mission is to produce and summarize and communicate knowledge to contribute both for public health and also for good health and care services in our country. So that's the way we try and contribute to better health in Norway and also globally. We work also globally with a responsibility for those areas where we have competence and responsibilities on the national level. Next. And these are the way we somehow put up our areas of work. We are on knowledge, preparedness, infrastructure, and knowledge. We do research, analysis, and we have a responsibility for surveillance systems. We do literature reviews and reports, news bulletins. And we're also hosting the Norwegian Cochrane Center, and it being the center of evidence-based medicine in Norway, which is a part of our institute. I'll come back to that. In preparedness, we have a lot of ongoing activities 24/7, being the lab for 30 diseases, and also we have a roster for people who do what we call the infectious disease telephone every day, every year, and we're the international health regulation focal point for Norway. Related to infrastructure, we keep a lot of the national registries, some of them in those brackets there, and also the labs, as I tell you, and a biobank. And this all ends up in recommendations, advice, information, publications, and communication that we are sharing with the public, and especially with the health personnel in Norway. Thank you. Next. Related to this disease, I think it's important, again, to remind about the disease pyramid, which is showing that there is a a deeper part of this pyramid where we still don't know a lot of things. How many are exposed? How many are infected without symptoms? And these are still figures that are not really clear in neither Norway nor Sweden or other countries. A number of minor investigations have been done. I think Iceland has been the one doing it most comprehensively, since they've tested many people according to the number of people in the country. And we still don't really know what is the number of people who have gone through the infection in many of our countries. And figures are varying from 7% down to below 1% in Norway, for instance, between Norway and Sweden. And then we have those with symptoms, which are kind of easier, and they are definitely also infective for a period, and also probably some of them who haven't really had their symptoms yet come out. Those in contact with a GP, those with a positive test, the hospitalized ones and the intensive care one, and at the end, those who finally dead. And we have different sources of data to deal with these statistics and find ways of also understanding how we can monitor and find ways of understanding how the epidemic and the epidemiology develops. And we've actually established now what we call BERET, which is a Norwegian name for preparedness. We've made a separate registry combining all these data sources with the death registry, the registry for intensive care, the national patient registry, infectious disease registry, and also registry of all those people who have seen the medical primary care doctors. So that's a way of trying to get an overview over the situation. Next. So this is the epidemic curve for Norway from yesterday, and we see there is this classical form of an epidemic curve. It went up straight up to the 12th of March, and that was when we had the first deaths in Norway, and we had the first 2 or 3 numbers of patients where we couldn't trace the contacts, we couldn't find the source of the infection. And that's when our prime minister said we have to come with actions for the whole of the society. And we had a kind of semi-lockdown of the society. I'll come back to that. And then from end of March, we've seen a very gradual and good going down of the epidemic until now, just having a few handful of new cases per day, and only, I think, 38 cases in hospital. And we have a total number of 235 deaths in the country. Next. So this is the curve showing just the difference between female and male according to the different age groups. And there has been some striking differences. In the beginning, it was definitely males being most affected. And then we see in some age groups, there are more females affected. So that could maybe be due to people working in the healthcare institutions. And the next slide is also showing a little bit of the distribution we have of the tests taken. The blue bars showing the number of tests, and the black line showing the number of positive tests. And we see this went quite up until we had a control over the situation, and the average number of positive tests being around 5%, now down to below 2%, showing that the spread now in society is under control. And we've taken 220,000 tests in Norway. Next. So the strategy, as I think in Norway, has been more or less the same as also expressed by WHO: to preserve health, avoid societal disruption, and protect economy. Next. And from the 12th of March, as I mentioned, then we used the word in Norwegian slå ned, knock down the spread, which was massive measures across the society for the purpose of preventing overburdening of the health services, and also to gain time to prepare at all levels in the society. And I think it wasn't a full lockdown. We had restaurants open, buses and public transport were open, but everybody were advised to stay at home as far as possible. And it was used also a legal instrument for those things that we say this is not allowed and this is allowed. For most of the things, it was still like advices that was not followed up by strict regulations. Next slide. And then from the 20th of April, this control strategy was formulated to say we start now with a gradual de-escalation, a controlled reopening of the society, and with the purpose of active testing, contact tracing, and isolation as the main instruments. And still, we shall be prepared for a possible re-escalation to happen of spread, either locally and nationally. Next. So, come again. stepwise now. Come on, we go with the next slide, please. That means there is these were the strategies. You can just go 8 clicks now. First, there was the care for the kids, and then to get people back to work, to keep social distancing measures and hygiene measures as long as possible. And I think that is possible to keep for a long while. To protect the vulnerable, to reopen leisure and fun, which is something coming later on. And we had this approach of a whole of society, all of society approach. And from a critical awareness of these things and getting it into daily routines. And finally, also with a global solidarity being very much important, I think, to try and stress in the situation. This is a real pandemic affecting almost all countries now, and we need also to find global solutions on how to treat it. So this was like the order of the reopening of the society. So now kids are back in school and kindergartens are open, restaurants are open as they have been, but with a wider opportunity also for people to go and also see each other, and to meet in up to 50 in arrangements and 20 in private settings. Next. And the gender perspective, this might be my blind spot then, since I'm a man, but come on, next click. And then we see all statistics on Corona have a gender as a variable. Please just click through. And then we saw in the beginning, more men were affected than women, and also more men die. And that still continues. But the difference between the sexes is actually leveling out. And what we've seen by doing systematic reviews of risk factors is that the overarching risk factor is age, not gender, or not underlying diseases. And then in the leadership of this pandemic in Norway, can you click through them all? We've seen at the national level, we've seen Solberg taking the lead. You know, she's a woman. We've seen at the ministry level, it was Mæland taking the lead. She's a woman. On the institutional level at our institute, it's Camilla Stoltenberg, she's a woman, and at the department level at our institute, it's Lene Wold, she's also a woman. So I'm like an exception being involved in this as one of the men here. And also the Minister of Health is a man in Norway. Next, please. And then I think it's maybe more important to have an equity perspective here in the global setting. Please click through. And then we see, I think these preventive measures might actually disrupt the economy for poor people to an extreme degree in low and middle income country. You cannot work from home if you have no electricity or no broadband band or computer. You cannot keep hands clean if there is no water or soap. And without travel and trade, there is no food for the day, which we've seen like examples of in South Africa, which I think is distorting. And also with the young population of Africa, I think it's extremely bad if they go on with the European ways of closing down society. And we've seen from Brazil that indigenous people are extra vulnerable, and they've also had no tests available, or there are no tests to analyze, no labs to analyze the tests. There are no hospitals with ventilators. And we've seen, I think, again, that primary health care and universal health coverage is the most fundamental thing also to stop this epidemic. And that purpose and a focus also on migrant and refugee health is very important in this situation. Next, please. So just to remind you again, we have this international health law, which all WHO member states have approved to, the international health regulations saying we should work together to prevent, control, respond to international spread, and without interfering too much with international travel and trade. Next. And in the first the public health event of international concern, it was actually stated, according to Article 44, all countries of this regulation are obliged to support each other in stopping the epidemic, both when it comes to financial, technical, and other resources. Next.
Also for you, Frode, you have to now to try to round off a little bit.
I will do that. Go on to the next then. I'll just mention then to, next slide, please. I'll just finish with saying we've done a number of things here to gather the evidence. So there's a map that you can find on the web. And the next slide will show you that we've done a number of rapid reviews. They're all in English, and they've taken forward this epidemic, the way of doing evidence-based medicine during an epidemic. And we've done systematic reviews within 2 or 3 days. Next, please. And finally, this is something said by the big leaders of a number of countries, that we're all in this together, and we have to really work through this pandemic in an international way to be able to combat it. And the final slide, I think, is just to say there are some few lessons to learn. And this is again to say what will be the future. And I don't think we will have a big autumn wave, as many people have said. I think we've had the first wave, and we've had small bumps. The last drawing you can see on that one, where we have now shown that it's possible to stop this epidemic by the interventions that we have taken. So I think that's the time run out then. The last slide was just saying a few words about learning points. You can flick through them, stick to the principles of preparedness and all of society approach. And these disruptive technologies is not the one that make this change. It's a disruptive event that also could lead to positive changes of society, that we can learn better to live together in a globalized world without destroying the globe at the same time. Thank you very much.
Thank you so much, Frode. That last line everyone would concur to, I guess, and we really hope to be able to do that. Can I just ask you, in Sweden there have been discussions about the healthcare services and the healthcare professionals in the elderly homes, for example, and that Norway has more professional staff in the elderly homes. Do you have any idea about that? Or I mean, one possibility for your low numbers of death, also for the elderly. But would there be more special care staff in health in the elderly home?
The homes for the elderly, we call them actually a home for the sick elderly in a way. You know, you can live somewhere when you are okay as an old people, but if you have diseases or dementia, you go to what we call sjukeheim, a home for the sick elderly. And that's where there is always a municipal responsibility for all of those. And there is a medical doctor responsible for it. I've been in such a position myself. And there are, of course, nurses running this together with also assistant nurses. And they're able to do minor procedures. And there is a doctor having an overview over the situation every day, if needed, every week, if it's a kind of low risk incidents. So I think the municipal responsibility is very strong, with a follow-up. And also in all municipalities, these doctors have the responsibility, the municipal health doctors, of infectious disease prevention and control for the whole municipality.
So that means also that you don't have to maybe send people who got a bit more ill to the real hospital, so you can take care of some of that within that home.
You can hang up a drip, but it's not really common to use oxygen treatment in a nursing home. But maybe if there is somebody with a chronic hypoxia, that can be done.
Okay.
But still in Norway, we've had the same challenge as in Sweden. We've had like 60% of our deaths in homes for the elderly. But still, we think if you get seriously ill and you're 90 years of age and you're having a dementia or other underlying diseases, you don't send them to a big hospital for a respirator treatment.
Of course.
So this is a way of thinking, I think, which is very much in line with Swedish thinking.
Yes. Okay. Thanks very much, Frode, for that. And I will then turn to Lina-Kajsa Tynkkynen and maybe also Sala Atkins to come in. And I give you the floor. So please welcome.
Thank you. Thank you. Can you hear me?
Yep.
Perfect. And Sala is there as well. Please go to, yes, and the next slide. Here starts our presentation. So we're from Finland, from the University of Tampere, and we wanted to start with these three pictures because the gender perspective was one theme of this session today. So if you look at the picture in the middle, you can see that our political leadership has been strongly sort of focused on women. So we have 5 women leading the country at the moment through this crisis. But then the upper picture, there you can see Mika Salminen, who's, I think you could say he's equivalent to Frode Forland in a way that he's also the chief or person responsible for the Finnish response on the Finnish Institute for Health and Welfare. And he's been one of the faces of the Finnish COVID-19 epidemic and the expertise around epidemiological expertise especially. And then if you look at the picture at the bottom of the slide, you can see that there is a panel of men who then represent the economic expertise and the discussions on how we should exit from the sort of semi-lockdown phase of the epidemic. And if you look at these pictures, you can see that the political leadership is strongly like feminine and female, but then on the expert side, the expertise has been strongly dominated by men. And I think this is an interesting sort of contrast, and if you're interested in the gender perspective. So here you can see how the Finnish picture looks like in terms of leadership and expertise. But now I give the Salla, the word to Salla, and she'll continue with a few slides.
Thanks, Lena. Guys, can we have the next slide, please? So in Finland, similar to what we saw in Germany, the regional difference is huge in terms of the epidemiology. So you can see in this first picture with the different blues that our epidemic has concentrated on the capital region and also the northwestern region, where the incidence per 100,000 is over 200. You can see on the right-hand side graph as well, when we're looking at intensive care by specialized medical care regions, and when we look at the capital region, which is the top graph, it far surpasses the rest, with the Tampere region, where we are, being one of the lowest areas of the epidemic. Next slide, please. We had the first case of COVID-19 in Finland on the 29th of January. It was also a Chinese tourist, after which it was still rather quiet in the front. Not much was done. But our epidemic really started when people returned home from northern Italy and Austria during the winter holidays in February. On the 10th of March in 2020, we already had 100 cases. And because of this, we started implementing restrictions on large-scale meetings with over 500 people, and this was done by the regional authority. On the 16th of March then, we found that our epidemic was increasing, so the state of emergency was declared by government, which allowed for using legislation for closing different places. And they announced additional measures of a semi-lockdown also on the 18th of March. Similarly to Germany, we didn't have any kind of restriction on public transport, going outside, exercising, or going to shops. But we did close schools and daycare, except for those children whose parents were in essential services. We closed sports halls and sports venues, theatres, museums, and we also restricted visitors to old age homes and care homes. Then on the 28th of March 2020, because of the epidemiological differences between the capital region and the rest of Finland, we also restricted movement to and from the Uusimaa region, which was maintained until the 15th of April 2020. So anybody without an essential reason to leave the capital region wasn't allowed to leave it. And we had the army and the police checking each car that they had a valid reason for leaving the area. The main reason for this was to prevent the epidemic spreading from the capital region with a higher ICU ability to the rest of the regions which had less capacity. And this was also over the Easter weekend, which is assumed to help a lot. Next slide, please. So we can see here the epidemic curve of Finland according to THL data. You can see that we had 100 cases on the 10th of March and 1,000 cases on the 24th of March. The THL testing strategy changed on the 14th of March, meaning that from that point on, we only tested severe cases and social and healthcare personnel. And this was kept up until the 15th of April, where because we had less cases, we could then start testing everybody. You can see that during these lockdowns, we increased the laboratory capacity to test cases, and we went from a few thousand to now about 6,000 per day. Next slide, please. And here we can see the same kind of restrictions with the persons hospitalized in general and persons in ICU, as well as the fatalities. And you can see that the curve is declining, with the peak of a curve around beginning of April. And you can also see that there's a peak in fatalities on the 21st of April, because this is the point where we also retrospectively added care home fatalities to the overall mortality data. Next slide, please. Liina-Kaisa is going to carry on from here.
Yes, and what we didn't mention in the last slides about the restrictions, we also closed the restaurants and bars since the early April, which maybe need to be included in the list. We've just forgotten them. But anyway, now since you saw that the epidemic is going down, the government has sort of declared a new stage in terms of the restrictions as well, and they've named this as a hybrid strategy. So if Norway had this control strategy, we are having a hybrid strategy, which means that the aim is to move from general restrictions towards more targeted measures, and also test, trace, isolate and treat approach, which is emphasized by the government. We've opened schools as of 14th of May, and but the schools will close after this week actually, because the summer holidays are starting. The bars and restaurants will open as of 1st of June. And also the gatherings up to 50 people are allowed as of 1st of June. Initially, there were also restrictions or advice for older people, those over 70, to refrain from physical contacts. But partly because of political pressure and heated public debate of this sort of restrictions that are based on people's age, the government has now sort of softened the advice and told that people are allowed to meet their family and visit the grandparents, but they advise to do that outside, not inside their homes. But there are still restrictions for visits to care homes and other care facilities. Next slide, please. We've listed some of the issues that have been discussed and that have been sort of topical during this 2 months of the epidemic. And one of the issues that we can still see in Finland is that the pandemic or this COVID-19 has been strongly framed by the influenza sort of frame, so that the Finnish preparedness has been based on influenza preparedness. Our preparedness plans for pandemics are preparedness plans for influenza, and that has sort of, at least at the beginning, sort of framed also the national debate and the political discussion. But I can see that we're now moving towards, since we have more knowledge and data, we also understanding the behavior of the virus better. At first we had lack of testing capacity and PPE, even though Finland is one of the countries that has never stopped stockpiling after the Cold War. But these stockpiles weren't actually too helpful, because some of the PPE that were taken out of the stockpile went, you couldn't use them, they were outdated. But anyway, the things are getting better now. The testing capacity has been increased, and also the availability of PPE is better as it was before. There's also the ICU capacity was increased, and it was it was limited because of the lack of personnel at the first, but we've never faced a situation where we'd had to ration care or anything like that. There's also been a lot of discussion whether as Prude already mentioned, a lot of things have been done through advice, these sort of softer measures, not actually through regulation or hard regulation. And there's been a lot of discussion now whether the government has been explicit in communicating the sort of the nature of the restrictions, whether they've been advised or binding in a sense. And Finnish health system is also very decentralized. So we have some 300 municipalities and 20 hospital districts that are actually responsible for the implementation of all these like care measures and also testing, tracing, and isolating. So in this sense, we've faced some challenges in terms of the national coordination and then the local level action. Next slide, please. And what we've been discussing a lot during this pandemic is also this knowledge-based decision-making. So in their government program, the Prime Minister Sanna Marin's government, they've sort of pledged that they are making knowledge-based policies. And in principle, I don't doubt that at all, but the access to information and the sort of the evidence behind the decisions, it has not been open, and there's been a lot of criticism towards both the government but also the ministries and national authorities that they're not releasing all the information that maybe should be available in order to evaluate the grounds of the decisions. So there's sort of this contradiction between this evidence-based policy and then openness of this information. And actually Norway has been referred to many times as sort of a good, like a...
Please try to finalize.
Yeah, we are just about to finish. So Norway's been referring to one of the good examples on how to sort of release information, and I know that the reports that Frode showed have been read among the Finnish academics, at least in Finland, and that's why we've sort of gone, because of these lack of openness, we've sort of the political discussion has been quite how do you say, maybe there's been also sort of discussion whether there's conspiracy theories behind this. There have been some conspiracy theories whether the government is actually aiming at this so-called herd immunity and things like that. So we've actually discussed a lot about these things, and not so much on, for instance, how municipalities are coping with dealing with this epidemic. But then Salla will say the last words.
Okay. Thank you so much from Finland, and both Salla and Liina-Kaisa. Can I just quickly go back to what you said, which I think is kind of fascinating, where you have some of the first slides you show, like the experts were all male, and the political responsibility and leaders were all women. What kind of influence and effect would that have? Something you just maybe briefly touched upon. We can maybe come back to that later, but I mean, that's quite interesting. So what do you think?
Do you want to say something?
No, Liina-Kaisa, you can take that.
I don't know if you can say too much about that, but there has been discussion about how there are countries led by women, like New Zealand and Denmark and Finland, for instance, that have been actually coping very well with the disease. I don't think there is any causality that you are led by women and then you succeed. So I don't know if you can actually draw any conclusions on this gender issue in terms of this. But it is interesting. And of course, for the media, it is very appealing to sort of raise this issue that, okay, young women are leading, now they are also succeeding with this epidemic, and then we have the United States and the Great Britain with this Donald Trump and Boris Johnson leading and not doing too well. So you can get this kind of contradictions, but I don't know if it's
okay. Yes, of course, this is hard to give any specific answer to, but I mean, I think it's maybe teaching the world that this can be the situation, and we'll see what it means. I mean, there's comparison also with New Zealand, for example, with a strong prime minister there. Okay, very good. Thanks very much from Finland, and now we turn to Sweden and Anna-Mia Ekström. Anna-Mia, please go ahead. Are you there, Anna-Mia?
Yes, sorry, I forgot to unmute. I'm here.
Great.
Thank you to my colleagues who have talked before me. I think it was really interesting to listen to you. So I'll give some examples from Sweden, but I've also added a global outlook in the end, sort of, I think, to promote the discussion that Frode also initiated on lockdown effects from a global perspective, in particular from a gender perspective. So next slide, please. So in Sweden, we had the first case on January 24th, a traveler from Wuhan who came back with symptoms. And then people were encouraged with symptoms, were that sort of created awareness. And then similar to the other Nordic countries, we had a school holiday in the end of February, from February 17th to 23rd, when a lot of people went to skiing resorts, including the Italian and Austrian Alps, and came back with symptoms. And this sort of kickstarted the epidemic in Stockholm in particular. And the health system also saw that the situation was escalating in Italy. So helplines were set up and mobile testing, drive-in testing. Intensive care units were scaled up and have now quadrupled in capacity in terms of beds, and still have some extra capacity to go. On March 11th, we had the first COVID death in Stockholm. The same day, many elderly homes closed for outside visitors. And in the middle of March, the 17th of March, high schools and universities were closed. Schools for small children have remained open for different reasons, mainly because a lot of the parents would be missing as healthcare staff, and also because there was a fear that the children would be taken care of by elderly relatives, which would be much worse, and also since we knew that children had a very, very low risk of becoming ill themselves. So, but most people were recommended to work from home, which is of course not possible for all, in particular those who may have care jobs and are from lower socioeconomic circumstances. So we see that the epidemic actually hit some of those suburbs harder of poorer socioeconomic status. So that was clear. It was also recommended that all 70 plus stay at home and not go shopping themselves, not use public transport, and physically distancing was recommended for all. Sport, games, concerts, conferences were cancelled. Everybody really stopped socializing in larger groups, and restaurants were checked, and many have closed down due to lack of customers. So you really see a huge difference in the streets of Stockholm and in Sweden in particular, and elderly are really not socializing with their relatives or with each other. So there are daily conferences from the Public Health Agency with an equal mix of men and women, I think. I think it's a very open discussion, actually, on mistakes that have been predictions that have been mistakenly done that don't seem to fit, and sort of from the Public Health Agency admitting that those predictions may be wrong. I also think that the difference between Sweden and many other countries is that the government has refrained from making politics of this and largely followed the advice from the Public Health Agency, and the politicians have not made any recommendations in conflict with the Public Health Agency. So the Public Health Agency has really been the dominating advisor on this, sort of letting the experts speak. And I think that has been both criticized by some, saying that politicians should go further than the Public Health Agency people, as they have done in all other countries pretty much, but they have sort of stuck to this, that expert advice and knowledge should prevail. And Next slide, please. We see that if in the previous, you see that a lot of the new cases are mainly health personnel that now have been tested, and testing is implemented more widely rather than a lot of people being sick. So I just wanted to say something about the testing, because the testing is one Sweden's greatest problem, because we have lagged behind in terms of scaling up testing. But for example, I think it was interesting to look at South Korea here, for example, which has been said to have implemented testing very widely, but actually the number of tests they've made is are very few as compared to the population, as Iceland is leading in this competition, if you see it that way. Next slide, please. When you see the deaths in Sweden, you see that they have really declined dramatically as a consequence of the restrictions, or possibly of increased immunity. It's hard to say. We had a large antibody, not that large, but at least representative, it's thought, study presented last week, and it seems like only 7.3% of people are immune in Stockholm, which was sort of a disappointment, because seeing that the ICU beds are becoming empty to fairly quickly, much less people are seeking care for symptoms, and deaths are really going down. It is assumed that this must be caused by some sort of immunity, although we may not be able to measure it with current tests. So this is a bit puzzling and being discussed very much in public media. You see that men dominate the deaths slightly, but not to a large extent, and as everybody knows, it's really age that is the main risk factor rather than gender. Next slide, please. This is also shown here that very few, 88% of the deaths are among the 70 plus, and only 4% of those below 50. Next slide, please. So I wanted to put this in relation a little bit. As I'm the last speaker, I have the advantage of sort of broadening up the discussioning a little bit. The relation of COVID deaths in Sweden to other deaths. We have about 90,000 people dying in Sweden every year. About 250 per day are expected to die then if you just divide 90,000 by 365. Meaning that we have about 36,000 people have died from other causes this year. At the same time, we have about 4,000 COVID deaths, making up about 11% of all deaths. And if you compare the sort of direction of the discussion, I don't think most people are aware of this actually. And the mean age of those dying from COVID is 82, which is sort of the mean age of people who are supposed to die from something anyway. Next slide, please. If you can look at COVID deaths per million in the world, Sweden has reported more than several other countries in Europe, and in particular some of the Nordic countries. So this has been much discussed. Was it because Sweden didn't enforce the restrictions? But the restrictions and the recommendations have been very similar. It's just that they haven't been legally enforced, and that we didn't close schools for small children. On the other hand, we still have high schools and gymnasiums closed, while other Nordic countries have opened up. So it's not that much of a difference as has been pictured in media. Next slide, please. COVID deaths then in different countries. Here you can see it's just a different way of showing it, where Belgium is topping this unfortunate league, United Kingdom, Italy next, France same on par with Sweden, while we have China, South Korea at the bottom, India and Russia still increasing. Next slide, please. This is also trying to put COVID deaths in relation to other deaths in the world. Given the debate and the extreme restrictions and sort of interventions that have been made for the sake of COVID, it's interesting to see that only 1.5% of global deaths so far in 2020 have been caused by COVID. And we expect this number to go down, since the countries that have been infected so far are the countries with the most aging populations. And while it's now spreading to countries with much younger populations. So on average, 56 million people die every year in the world. And so far, 23.5 million people have died from other causes, which is something we don't hear so much about. Next slide, please. So in relation to what I said before, the countries that have been affected by COVID so far are the countries with the oldest populations primarily, while Africa has only 2% of its population above 65 years of age. And therefore, and has had very few cases also due to very early lockdowns, which unfortunately has also affected the trade in Africa to a very large extent. And half of all Africans who have a job are expected to lose their jobs due to the restrictions. We also know the poverty is expected to increase dramatically, maybe losing up to 3 decades of development due to the restrictions of COVID. And thinking then about the prospects of very, very few actually dying from COVID in Africa, one may ask whether this actually makes sense. The next slide, please. So what can we expect then in terms of having a gender perspective, global gender perspective in excess burden disease for women and children due to the COVID lockdown? What do we already see? Peter mentioned initially, very interestingly, that it's expected that maybe 2.7 million unsafe abortions will be caused due to lack of access to care and also medication and staff. Adding to that list, this is UNICEF's worst case scenario, I should say. It's not the medium or mild case scenario, but up to more than 40% increase in under 5 child deaths. Up to 1.2 million children extra could die from fully preventable causes only in the next 6 months. This should put in relation to the 400,000 that have died from COVID in the world, which is then a small share of this, and it's mainly people above 80, and here we have children dying. I'm not comparing the value of people, but if you look at life years lost, I still think we lack an ethical discussion around the priorities we make today. We may also see up to a 38.6 increase in maternal deaths per month, meaning up to 56,000 more maternal deaths, adding to the 144,000 maternal deaths we're already seeing, most of them preventable with through health system interventions and birth with skilled birth attendants. We also see that about 370 million children now lack food due to school lockdowns, where they normally get the most proper meal of the day, and now starvation is increasing. 130 million more are predicted by the World Food Programme to suffer from severe hunger due to COVID financial effects. This is in addition to another 135 million new people who are expected to transition into severe hunger this year due to locust swarms and flooding in particularly the African continent. We also see that many children are at risk of missing their measles vaccination, causing a pandemic in measles, which is hard to predict the consequences of. Since 95% of the drugs on the African continent are imported, we already see a lack of. I'm on a daily basis in contact with my African colleagues through a lot of common research projects, etc. And you already see a huge lack of contraceptives, condoms, HIV drugs. People aren't coming to pick up their HIV drugs. They're afraid of getting corona, or they're stopped by health staff, or afraid of becoming infected by other patients. There's a lot of corruption in money donated for personal protective equipment that is sold in the black market. We see a lack of anti-malarials, parents not bringing their children to a hospital. In Uganda, for example, private transport has been prohibited, so you can't actually get there. It's not allowed to go by car, taxi, boda boda, or anything. It's stopped. So there's no way for parents to bring their sick children to hospital due to the lockdown. We also see a very worrying increase in gender-based violence. And we also see that this is associated with food insecurity, stress, and isolation all over the world. Next slide, please. So the question I would like to ask the audience for the upcoming discussion is, are we aware of what we are doing with these COVID restrictions? Are we aware of, are we making the right priorities? I sort of feel a lack of a proper discussion around saying that you cannot select something without deselecting something else. you need to make priorities. If you choose to prioritize one disease, that means you need to down prioritize efforts on everything else. And that is what is happening. And if we choose to prioritize ourselves in high-income countries in the north, we choose to down prioritize everything we do and trade in terms of trade, aid, and everything else in the countries in the south that are not really at risk of being affected by COVID. But we know for sure that they are at risk of being affected by a lot of other illnesses and diseases that are preventable, and especially among younger generations. And do these interventions that we have made in the name of COVID benefit women and children? I would like to open up for a joint discussion on this. Thank you.
Okay, thank you so much, Anna-Mia, also for your global perspectives. There is just a very brief question to you from the out in the internet from Niges. The immunity is said to be 7.3% in Stockholm. Do you have the figures of Sweden? It's very big regional differences, but the average for Sweden?
The average for Sweden, I think we see it is around 4% in the south and sort of in the lowest, but people are starting to doubt actually how optimal these antibody tests are. I have seen from my own studies at the hospital and what people are starting to present preliminary data that people that we know for sure have tested positive through PCR, through the virus test, sort of in the nose and in the airways, are coming out negative in the antibody tests. So they were said to be very, very good, and I thought we hoped that they would be very good, but there is some doubt now to actually how well antibody tests measure immunity that is relevant for COVID. So I think we don't have the full answer there. They might measure existing antibodies very well, but there may be other cell-mediated immunity that we don't know enough about actually. And the downturn in deaths that is so striking in Sweden and in many other countries actually, while antibody protection is still very low, far from what we would expect needed for herd immunity. Sort of the numbers don't fit. The numbers and the models that we see don't fit in any country really. So there must be something here that we're not doing right. Yeah. Either it's the modeling, meaning that we would have a huge spread, but then the deaths and cases should continue at the same rate and not go down. So something is weird that I think we'll soon find out more about.
Time will hopefully tell, and science will tell us, hopefully. Just, I think, a quick thank you very much, all of you. And I hope everyone out there are enjoying listening to these very interesting talks. And also there are some questions that we might come back to a little bit later on from you. Just to the panelists, just interesting to a quick response to for representing your countries. What are the effects, like other diseases? In Sweden, we have discussed about maybe there's a reduction of, for example, people with angina, possible myocardial infarctions, strokes, and other common diseases that we see every day. They have been reduced quite substantially. So because people are probably afraid of going into the hospital because of the COVID and so on, but suffering maybe even more. What does it look like in your countries? Just quickly, to start with, Iris.
I'm not an expert on that, but there has been a lot of warning from the societies on cardiovascular disease and also on psychological effects, depression, etc. But I haven't seen any studies that substantiate that. So I think we will have to wait for studies.
Okay, Frode?
Yeah, there are several interesting aspects related to that. First, just like a comment to Anna-Mia, because what we've seen in Norway is that we also really think that the effects of the societal measures are the one we are seeing in society, not waiting just for the antibodies. we see the effect of social distancing, of hand hygiene and coughing etiquette having a striking effect on slowing down this disease and all other infectious diseases. We've seen a 61% reduction of sexually transmitted diseases, of food and waterborne diseases, of all other airborne diseases. So it shows that these kind of basic infectious prevention control measures have also had a huge effect on other diseases. It might also be due to lack of awareness of them, since we've been too busy with the corona business. So that's also a possible explanation, but it's also definitely something about the way we now interact with each other, making it much more difficult to be infected by each other. When it comes to non-infectious diseases, we've seen like a queue piling up with some of at least expected procedures in hospitals. So that's a problem that we are now coping with and putting things back to normal, which is the situation again now.
Yeah. And Sanna and Lina-Kajsa?
In Finland, we're seeing a similar pattern. So the other diseases that we would usually see, we don't see. But we've also seen a pattern where people are afraid to go to primary healthcare, for example. And even if there are sort of distance or options available, it's not covering that gap. So the services are really being underused. But then we also have that hand hygiene and so on that's showing in the pediatric population, where there are less infections among them, that children are healthier because they're not seeing friends, because they're not in school and so on. But that's also one of the issues that I wanted to mention about Finland, which is maternity care, for example, and immunization rates have gone lower, as have abortion and contraceptive care.
Yeah, thanks. And there's Anna-Mia from Sweden.
Yes, I entirely agree with you, Frode. Of course, the social distancing has made the difference entirely, but that's what made it go down quickly. But now, as we're opening up, I think that's when we will learn how much of this, how quickly will the cases come up again. That's the one we will see, the effect of the restrictions versus the effect of any potential immunity. And in Sweden, we have seen the same effect of RS virus, for example, in children gone down dramatically. The influenza epidemic completely ceased, the normal flu entirely. So that's because, of course, of hand hygiene and people of social distancing. So this has been, of course, had the most dramatic effects. But it is still a little bit weird to see that the cases are going down so rapidly now, and there should only be like a 2-3 week delay between infection and death, pretty much, or a 3-week delay, something like that. And we see that the restrictions then it should have had a slightly quicker effect if there was no effect at all of immunity. But it's very hard to tell what is what right now, actually, and which restrictions that are most effective. So a lot of the evaluations and predictions we make now will be, proven wrong in the future. So in a way, we're doing some sort of natural experiment all over the world with having different restrictions at different phases. And this thing will be extremely valuable for the future, for future pandemic, because this is obviously not the last outbreak we'll have. There will be new viruses coming along. And I think we will have learned a lot from this that will be extremely useful, both in terms of public health interventions, but also vaccine development and drugs. So hopefully the world can learn and react better next time.
Absolutely, we will learn. So this to continue on that track a bit, that means also how to deal with the political pressure versus the science and the experts, and that have been very interesting approaches for many countries in the world. I'm turning to you, Iris. What do you think is the scientific evidence to support closing borders and shutting down business and schools and so on to try to stop the spreading? And how do we actually know that people then will follow these measures? Do you have any comments on that?
Yes, I do have that. I do have comments. I mean, the RKI prides itself on working or developing recommendations based on evidence, and it has been very vexing to us that there is so little evidence for community-wide measures. In fact, the evidence is extremely limited. The evidence we do have is mostly gathered from modeling, which is not such a high degree of evidence, and a bit from some studies on influenza. And we do have some evidence that mass gatherings and early and long school closures have an effect on an epidemic. And you will note that this is exactly what Germany started with. There is this effect of mass gatherings and acute respiratory infections that we see every year with the Hajj, for instance, etc. And we also see that early school closures have an effect on epidemics. So we started with that. We also see that there is very little evidence on public transport. Public transport does not seem to be associated with a higher risk of infection for respiratory diseases. And the same is true for wearing masks in public gatherings. You probably heard about the issue about mask wearing in Germany. I mean, the RKI was very reluctant to even address wearing of masks in the beginning because of the little or no evidence that it would have an effect. But also because in the beginning, because of the lack of availability, we feared that if we recommend masks for the public, then there wouldn't be enough masks for the medical staff. So it was not encouraged. It was not disencouraged, but we basically did not address it. And then when the pressure basically increased for lifting measures from the political side, but also from the society, people became, they were just not as patient any longer. Towards the end of April, early May, the ICU units remained empty, and a lot of people did not have cases in their immediate environment, so they basically couldn't experience the epidemic. So there was this pressure for lifting measures, and we also had these pictures from Asia and especially from South Korea, people wearing masks. So there was this logic behind having a mask and then feeling safe. It also kind of helped people to feel that they could act, that they could protect themselves. And you can argue as long as you want that a mouse nose cloth cover, as we call it, we don't say mask because that's a medical device. That's not what most people wear. That this is not protecting yourself, it's helping to protect others if everyone is wearing it, but only to a certain degree. But people don't, I think they just don't feel that way. The experience is I have something on my mouth and nose, I can't breathe bad stuff in, so I'm protected. And the effect of that is that they don't keep the distance any longer. And you can see that everywhere here in Berlin. So
you see that as a very coming threat.
I think I stop here. I mean, this limited evidence has been, as I said, very vexing. And I think we need to look back and try and find the changing points in the epidemic curves in different countries and try to kind of combine them with the measures that countries implement and then try and see whether we can learn something.
Yeah. So going on that same theme to you, Frode, do you think that there have been extremely, your mechanisms of the lockdowns or the shutdowns in Norway, and also, of course, the social distancing, is the key effects in Norway? And how do you see them to prevent the possible second wave coming up?
I think it's crucial now to be very alert when it comes to reintroducing the different stuff, because we had this kind of rapid close down, and now we're having a gradual reopening. And the rapid close down was with some few things being evidently effective and a lot of things being without much evidence. And our institute didn't recommend school closure or closure of kindergartens. We did not recommend closure of borders. We did not recommend people from going to their summer houses, for instance. So that was because there was weak evidence only from influenza studies on a number of these things. But some of the other things, we are sure that it works with good hand hygiene and also with good coughing and sneezing etiquette. So there are some of the things here that we knew from evidence was effective and a lot of other things not. And then we've actually tried to install an RCT in Norway on the reopening of schools. And that was actually not recommended by the Ministry of Education, to try and reopen schools in one county first and in another afterwards and see. So it's also difficult to do research on these societal interventions. And the question on face masks, again, it's like coming from East to Europe and now going north. And I think we have a very common approach in the Nordic countries and still resisting. And you need to, we are actually talking now, doing a systematic review on face masks again. What are the numbers needed to mask to prevent one case? I think that's a case we are discussing these days with Andy Oxman and his studying group on the evidence-based movement. And there are huge numbers of people that needs to wear masks for many days to prevent one case, I can tell you. So we'll come up with some more results on that by end of the week.
We look forward to reading about that, really. Yeah. Thank you. And turning then to Finland, to Salla and Lina-Kaisa. It seems that you have managed very well in Finland to deal with this pandemic. And what would you then recommend, what you have learned so far for other countries now for the continuing process? And I was speaking maybe more, or thinking more about the spread of the virus and so on, because we have to also to face all the social consequences, of course. But that's for the not to prevent the second wave or the third wave. So, what were the best piece of advice you will get to countries?
Well, I think at this point it is very difficult to say, and because as was already mentioned, it's really hard to.
If you will try to see what you have done so far and the effect of what you have done, from that, what would you say then?
Well, I think that one of the things is that we put the semi-lockdown on very early on. So we actually had very few cases, probably very few cases, as we already put in these hard restrictions. And what I also think might have been a good thing is that, as Salla described in our presentation, the epidemic is mainly centralized in the capital region, so it has not spread throughout the country. And when we locked down the Uusimaa region, or closed down it so that we couldn't move to or from the capital area, that might have been a good thing, since it was during the Easter holidays and people tend to go up to the north to have their skiing holiday, to skiing and staying on cottage. So that might have been one of the things that has prevented the spread wider in the country. Yeah, but that's, Salla, do you want to add something?
I think one of the key things is that using the time, if you do have a lockdown, to build capacity in other areas like we've done. We've built capacity in testing, we've trained ICU personnel, and we've trained tracers for the coming out of the lockdown. So I think that's something that is maybe a good thing to do in future pandemics as well.
Mm-hmm. Mm-hmm. Okay, thank you. And Anna-Mia, do you think that the Swedish way of doing things, which has been very, very globally discussed, do you think it's the right way to trust on people's doings and not strictly regulate so much, but just believe in people that they will follow the recommendations?
Well, I think the development is, I mean, Swedish, as I tried to list here, Swedish recommendations have actually not been very different from most other countries. And I think the Nordic public health agencies have agreed quite a lot. They've had the same strategy pretty much, but then it's the enforcement of the regulations that I think have differed between countries, but also political advice that have sort of deviated from public health agency advice in some of the Nordic countries. So I think the experts have agreed largely, actually. as Frode said, they didn't recommend to close down schools for children. They didn't recommend closing of borders. They didn't recommend people to prohibit them to visit their summer houses, etc. But that was still done by the politicians, not based on evidence, just based on political pressure. So
how do you
I don't think maybe those interventions didn't have a lot of effect. So, but what we failed to do in Sweden, what has been a lot of discussion, is to protect the elderly in the elderly homes. And if I may show that picture, just because I think it's an interesting discussion. It was my last slide. Here, what is interesting actually, and what the National Board of Social Welfare commented on this weekend, was that if you compare the deaths and as Frode said, this is not for elderly in general, this is a very sick elderly. It's only 2% of those 65 to 79 that live in these homes, and they have a lot of multiple diseases. And mean age of moving into these elderly homes is 86 years for female and 84 for males. They're very old and very sick. So normally 1 in 5 of these guests or these elderly die within before 1 month after moving in. If you compare the deaths in these homes among elderly from last year, the exact same time period, which is the flu season, 10,000 people died in these elderly homes, and this year 11,000 people died. So it is possible that many of these elderly would have died from normal flu otherwise, because they're very, sensitive, they're at very high risk of dying. And this is where people die normally. So I think some of the deaths that we see now may be people that were at very high risk of dying from something over the next few months. So many of these might have died from flu, etc. But the one big problem that we have seen, and that has been highlighted for this, is that the management and the training of the staff in many of the elderly homes has not been optimal, but far from it. And we've lacked a lot of protective equipment for the staff. And so in particular then women, lower educated women, many foreign-born, have obviously not been prioritized in terms of getting the protective equipment they need in their jobs, if you compare to doctors in the hospitals. And this we think, has been one of the reasons why it has spread so unfortunately in the elderly homes. Also, the management has not been coordinated, maybe as well as in our Nordic and neighboring countries. We have many privately run elderly homes with a higher density of patients per staff, and with many lack formal education, which is also a problem. We also closed the visits to elderly homes quite late on March 31st, which we probably should have done much earlier. So there are things that we can really learn from this, that I think mistakes that were made in the elderly homes, but which is also where most of the COVID deaths have occurred. But as mentioned, many of these are at very high risk of dying in any normal year, as shown by the statistics from last year. Thanks. So it's hard to say, but certainly there will be lessons learned here in terms of management, training, and protective equipment for the future.
Definitely so. In the interest of time, we're just about to finish. I would just like to hear your final question to you all, and a brief, more or less yes or no. But then that's a question also from the public, so to speak. Could the European Union have done more to disseminate experiences across Europe and help more? Finland, any one of you? Sala.
Well, certainly it would have been useful to, I believe that we did listen to other countries, and much of the things that we did were based on what other countries had done. So I think there was a great deal of learning, but it might have been better if it were rapid. And
yeah. Thank you. Frode?
Yeah, I think the EU has been struggling here really to see its potential. You know, I was working at the ECDC, and I'm now in the advisory board of ECDC, and I also listening to the Health Security Committee meeting. And I think they have really been trying to find a way, but the countries have done what they want to do, and they've not really fully regarded what has come from ECDC. And I think also ECDC had problems of really doing what we needed to do the evidence assessments rapidly. And they've been struggling to find ways of also dealing with models for the whole of Europe, trying to make models that fit for everybody, which have been also very much, I would say, poor models that we had to criticize heavily before they were released. And just to say at the end, I think we should have a huge caution related to using models. We're putting a lot of things into difficult equations, and nobody can understand what happens in there, and outcomes an R at the end, which is a magic number that everybody thinks is the most important thing for the epidemic. So it like takes away a common judgment and ways of understanding experience and knowledge by putting it into numbers, which is a kind of school for mathematics and not for public health physicians or staff.
Well, combination might be good, but
yeah, sure, that's true.
You have to be realistic about them to trying to interpret them. Iris.
Yeah, just one short comment. I think what really went badly in the beginning, and that's not an easy task, but is kind of like sending teams of doctors to the most affected areas. Yeah? That we had Chinese doctor teams, whether they're helpful or not is a different question, going to Italy instead of having our own teams of European doctors helping Italy. Or what we later did, of course, taking patients from the most affected areas and treating them somewhere else across Europe, that I think should have worked much better. We have these emergency medical teams. There is this mechanism, and it simply needs to work better next time.
So the answer was clearly yes. Then we could have done
yes, certainly a yes.
And Anna-Mia, very, very short.
No, I agree. I don't think this has strengthened, European collaboration, unfortunately, but rather the opposite. Countries sort of taking or sort of equipment from each other, stopping equipment from being transported between European countries. That was not a beautiful, record. That's something we can't be proud of. And so I think we can only do better from now on. And that's also a learning for the future, that this was not nice. And I'm afraid that, nationalism might and increase. And I think some of the questions here is also the democratic human rights have been infringed upon in the name of Corona. And that's something we really have to look up for in the future, also in some of the European countries where democracy is threatened. Something really to keep an eye on.
Yes. That is what I will say also would be an extremely important learning. And thank you everyone for participating. Just to conclude, to say that if we do not work more together in this, there will be serious difficulties in fighting this virus and also fighting the consequences. So the globalization and the communities discussing with each other and helping each other is absolutely a prerequisite for dealing with this. And that is also how we learn from what the experience and this kind of national experiment will yield in times to come. We can't do it everything at the moment. And we need, I think, in light of globalization and trying to do things together, I think we need very much to support the WHO. And we know that there's been very much critique from the US and freezing the money. And in addition, now lately also to maybe withdraw completely from the WHO, which is absolutely madness in my view. So this is something that we need to fight. And I think there's a lot of NGOs out there fighting and saying that we need to support WHO. But I also want to see the member states and leaderships and governments speaking up, and the politicians speaking up also for the WHO, because that's the only universal health organization we have. And that is absolutely needed in these cases. And we need also to emphasize, speaking about also the WHO and the World Health Assembly. And the founder, the co-founder of the Women in Global Health, Rupa Dutt, wrote an article here in the Think Global Health magazine, that the gender, regarding the gender perspective, and that has been going backwards a bit, and that it's also a struggle to fight for that women should also be in leading positions, not just in politics, but also expert-wise, and that it should be a balance there. So we have a few more common things also and tools to fight this pandemic and the consequences of the pandemic. So with those closing remarks, I thank the panelists very much indeed. for the reviewing your country's situations, and also everyone out there listening. Thank you so much. Bye-bye.
Tack Peter.